Bismillahirrahmanirrahim. To our respected members in the ophthalmologist WhatsApp group, this is our first Zoom meeting, and I want to thank Dr. Abdul Balushi, who is an assistant professor and consultant at King Saud University in medical retina and uveitis ocular immunology. A brief intro about him is that he is Saudi boards and King Saud University boards. After that, he did fellowship from Royal College of Surgeons, Glasgow. And later on, he went to Moorfield Eye Hospital, UK, to do his subspecialty fellowship in medical retina and uveitis. Today, we are going to discuss Dr. Balushi, especially about the research which was conducted in King Saud University and which was statistically proven that there is a window period in the treatment of VKH. We will talk to him, what is that window period, what is its significance, and how did, after years of research, did they prove that this is of significance in the treatment. So without further delay, I request our respected guest and speaker, Dr. Abdurrahman Al-Balushi, to present his talk, please. Yes, Dr. Balushi.
Thank you, Dr. Alim, for inviting me and for the nice introduction. So I'm going to talk now about Vogt Koyanagi Harada disease. So as we know that in our previous studies, local studies, VKH is the most specific uveitic entity in our region in Saudi Arabia. In a largest series that we published in 2018, around 18.7% of the all uveitis cases were VKH. It is not actually only in adult, but also in pediatric and children. It was the most identified specific uveitic entity among the other groups. So as all we know that VKH is a multisystem T lymphocyte mediated autoimmune disease directed against one or more antigens found on or associated with uveal melanocytes. The disease typically exhibit initial onset disease with bilateral granulomatous stromal choroiditis. This is the initial disease. Then the secondary oxidative retinal detachment in addition to optic disc hyperemia and swelling will occur consequently. If the patient is not treated adequately or present late, the disease will convert into chronic recurrent granulomatous anterior segment inflammation with typical sunset glow fundus and chororetinal atrophy. So the patient will convert from the initial onset to chronic recurrent stage. So this is the basic concept of VKH disease. VKH is a primary stromal choroiditis. VKH disease affects pigmented races and individuals with a specific genetic predisposition. That's why it's common in our region, and we know in the West, VKH is rare. The disease is always bilateral. However, asymmetric presentation with unilateral oxidative retinal detachment may occur. The mean age at presentation is around 30 years. There is a slight female predominance occur in the female patients in around 60%. So this is a classic case of initial onset acute uveitis associated with Vogt Koyanagi Harada disease. So you can see that the patient presented with bilateral optic disc hyperemia and sometimes swelling, bilateral oxidative retinal detachments, and if fluorescein angiography, you can see there is a pinpoint hyperfluorescence at the level of the RPE, and late you will see the optic disc leakage and staining in addition to the pooling of the dye under the area of oxidative retinal detachment. ICG is very important to make up the diagnosis as it can show the extensive granuloma as it appears in these two pictures in the right and the left eye. So you will see multiple hypofluorescent dark spots which indicate the granulomas in addition to the hypofluorescence corresponding to the area of oxidative retinal detachment. So to assess, to diagnose the VKH, we need to have a proper assessment of the choroid, mainly ICG, and EDI OCT were also helpful. And recently we did an effort to look for the choroidal blood flow in a patient with VKH with using a red flow or laser speckle flowography machine. So previously, we published this paper from our institute, King Saud University, and now we are publishing another paper. It just get acceptance in Acta Ophthalmologica about the indocyanine green angiography findings in initial onset acute VKH disease. And the most consistent finding in those patients is the presence of multiple hypofluorescent dark dots that indicate that the patient has full thickness granulomas, pinpoint hyperfluorescence, scarcity hyperfluorescence, hypofluorescent patches corresponding to the area of exudative detachment, and etc. EDI OCT is also very helpful in those patients, as all those patients at presentation showed increased choroidal thickness, as you can see here. So the choroidal thickness in EDI OCT, it can exceed the 800 microns to the extent that you cannot see the scleral edge. However, after the treatment, you can see down here in the right eye, the choroidal thickness returned to the normal thickness after appropriate treatment with systemic corticosteroids and immunosuppressive agents. And this is the third way that we are looking to the patients with VKH is the choroidal blood flow impairment. And if you see that the color map in the left side with acute VKH, the blue color indicates that there's a severe impairment to the choroidal blood flow compared to the normal eye, where you can see the color is green or red. And this is what happened also in a patient with central serous chororetinopathy, as it's a common thing, or common confusion can occur between initial onset VKH and CSCR patient. So VKH disease, previously, it is known to be classified into initial onset acute or chronic recurrent stage. However, nowadays, in the previous few years, we subclassified the patient with initial onset acute into early presentation with quiet anterior segment or late presentation with inflamed anterior segment. In our hospital, King Abdulaziz University, at King Saud University, our treatment for all patients with initial onset acute VKH, usually we start IV methylprednisolone 1 gram daily for at least 3 to 5 days, and a similar thing for children, 15 to 30 milligram per kg of the body weight. This usually followed by oral prednisolone 1 milligram per kg in a slow tapering manner. Plus, at the same time, we will start a second immunomodulatory agent such as mycophenolate mofetil, cyclosporin, or methotrexate. This will take us to a new concept that we need to focus during this talk about the catching the therapeutic window of opportunity in early initial onset Vogt Koyanagi Harada disease. And as we know that the window of opportunity is a well-established concept of critical importance in rheumatoid arthritis, and considerable attention has been paid to when it might close. The window represents a very early phase of the disease in which the therapeutic disease modification is more successful, presumably because of not fully matured underlying disease process. A growing body of evidence has emphasized the consistent clinical and radiological benefits of prompt initiation of disease-modifying rheumatic drugs in a patient with rheumatoid arthritis during the early stage of the disease. Therapeutic intervention in this period alters the natural history of the disease and hampers the disease progression in such a way that chronicity is reduced. Furthermore, early intervention results in a greater proportion of the patients in a drug-free remission after treatment withdrawal and reduces the mortality rates. These findings have led to changes in rheumatoid arthritis treatment paradigm, with increasing emphasis on early diagnosis and treatment. So in our first paper that we published a few years ago, we looked to our patients with VKH disease. And as I told before, that we usually classify our patient into 3 subgroups: initial onset or chronic recurrent, and the initial onset without anterior segment inflammation, and acute VKH with anterior segment inflammation. We found those patients who presented very early in the disease course, when the inflammation is confined to the posterior pole without anterior segment inflammation. None of those patients develop any complication during follow-up. So no sunset globus, no choroidal atrophy, no cataract glaucoma, or choroidal vascular membrane. However, those patients who presented late, good number of those patients presented with complication. This led us to publish our second paper, which was published last year, about the therapeutic window of opportunity in a VKH disease in a large series of VKH. And we found the same thing, that those patients who present early, none of them developed complications. We have only 2 eyes, and actually this patient was elderly patient who had who has a cataract since presentation because of age. But when you look to the patients who presented late with anterior segment inflammation, good number of them, they develop complications, and around 30% converted to chronic recurrent evolution despite the aggressive treatment. So how about children? VKH, as I mentioned, is common in our region. So this is an 8-year-old girl who presented late with bullous exudative retinal detachment, as you can see in both eyes, severe optic disc swelling and hyperemia that causes severe leakage on fluorescein angiography. And you can see on EDI OCT, the choroid is very thick in both eyes. VKH was reported in a 4-year-old child in Saudi Arabia, and actually I personally have a child who is also 4-year who presented with VKH. Unfortunately, those children usually present late because they don't articulate their symptoms early, and they present when they have anterior segment inflammation. So sunset glue fundus complications are common in those patients. So we published the largest series of Vogt Koyanagi Harada disease in children, and we found similar to the adult population. Those who presented early without anterior segment inflammation, none of them developed any complication during the follow-up, which tell us that the therapeutic window of opportunity is also exists in children. So this is an example of a 15-year-old girl who presented early when the inflammation was only confined to the posterior pole without sunset glow without anterior segment inflammation. And if you look down, this is after the treatment, the fundus returned to the normal with no sunset glow fundus, no complication. And this is an example of another child who presented late with anterior segment inflammation. And you can see that this child ended up with sunset glow fundus, pigmentary changes, and poliosis. So how about pregnancy? So we know that pregnancy commonly induces relatively immunosuppression. However, we have 10 women presented with initial onset acute VKH during the pregnancy. And we published this last year in 10 women who presented with initial onset during the pregnancy. And similar to the children and to the adult population or regular patients, we found those who presented early with quiet anterior segment. None of them developed complication, and all of them developed 20/20 vision at the last follow-up, which seemed that the window of opportunities also exists in a pregnant woman. So this is an example of a 24-year-old pregnant woman presented in her 13 weeks of gestation. The patient treated with corticosteroids combined with cyclosporine, and as you can see in the last follow-up, there was no sunset glow fundus and choroidal thickness returned to the normal. As I said, VKH is always a bilateral disease. However, we have a good number of patients, they can present with unilateral exudative retinal detachment. So we published this 2 years or 3 years ago. 5 patients presented with initial onset acute VKH. However, the exudative retinal detachment was only in one eye. But if you look to the indocyanine green angiography, you can see that the patient they have a bilateral choroidal granuloma, which means that the exudative detachment is a secondary phenomenon and the primary disease in the choroid. So it's always a primary choroiditis, bilateral choroiditis. This is another example of a patient presented with left exudative retinal detachment. However, the indocyanine green angiography showed bilateral choroidal granulomas. And similar to the pregnant children and regular patients, those patients, if you catch them early, none of them developed chronic evolution or sunset glow fundus, which means also the therapeutic window of opportunity exists on those patients. So in our previous studies, it clearly demonstrates that none of our VKH patients who were diagnosed and treated during the acute uveitic phase without anterior segment inflammation developed any uveitis-related complications. This indicates that there is a window of opportunity of highly successful treatment of uveitis associated with VKH disease during the acute uveitic phase without anterior segment inflammation, suggesting that early diagnosis and immunosuppressive therapy is crucial to step toward achieving optimal control of uveitis associated with VKH disease. This window represents a very early disease phase in which therapeutic disease modification is more successful, likely because the underlying disease process is not fully matured. So by this, I will conclude my talk, and thank you.
Thank you, Dr. Balushi. It was really very nice and detailed, and you really covered almost all aspects of VKH in children and in pregnancy. And especially at the end, you also concluded about this window period concept that was given by King Saud University UVEITIS team. So if we can say that before the development of posterior synecdoche, anterior chamber inflammation, synecdoche, if the patient gets the treatment, the results and the prognosis will be very good. But once the synecdoche develops, an anterior segment is involved, the prognosis and the treatment will be lengthy.
Yeah, true.
This is the main point.
So yeah,
Second,
so just I want to highlight that anterior segment inflammation in form of granulomatous and KBs, Socratic precipitates, posterior synechia, cells in the anterior chamber, iris nodules, all these features is associated with worst outcome. It means that the patient become late.
Okay. The second thing, Dr. Balushi, I wanted to ask you, this is a tertiary care hospital, mashallah, where you people are working and doing research, a lot of things. But many of our WhatsApp members and other people who will see this video, they are working in field hospitals or the hospitals and the areas which are, these facilities are not available. I'm particularly talking about mycophenolate mofetil, yani its cost and affordability in those regions. So how you practically guide them? What are the alternates for them to handle this disease if CellCept affordability is a problem there?
Yeah, so we commonly use CellCept in adult patients because of the safety profile of the CellCept compared to the cyclosporine and methotrexate. It's very tolerable, fewer side effects, and very excellent outcome. However, in pregnant women, as I mentioned, that all of them we give them cyclosporine because it's safe during pregnancy. It's safer than mycophenolate or methotrexate. So another good option is cyclosporine. Cyclosporine, it works very well in during pregnancy, and we tried in many patients as alternative to mycophenolate. It works similar to mycophenolate. It prevents the development of sunset glue fundus and all complications. The other option is methotrexate. So methotrexate is a cheap, I think it's available medication. We use methotrexate frequently in pediatric population. It's a very small, tiny tablets, easy to swallow. However, the side effect like GIT problem, vomiting, nausea, these things makes us not using it frequently in adult, but it works similar to the methotrexate. So our children who used methotrexate early in the disease course, none of them developed any complications. So you can use whatever available in your hand. In our experience, cyclosporine, methotrexate, and mycophenolate all works with a similar effect.
One thing more, Dr. Balushi, that the early detection, many of our colleagues, general ophthalmologists who are working in the field or different hospitals, general hospitals, it has been observed, and it was earlier also discussed, that it is sometimes confused with the CSCR, and they spend a lot of time in detection. And when the disease progresses and goes into late stages, then the patient comes to the tertiary hospitals. So what do you suggest? Inshallah, we will have a specific talk about this also. But what do you suggest that this early detection of differentiation in the field hospitals, general hospitals, how it can be done over there.
Yeah. So simply, history is important. So if the patient have the prodromal symptoms such as headache, tinnitus, uh, fever, or flu-like symptoms, so this suggests more of VKH. The other thing is OCT. OCT, the simple OCT is very helpful because the features of CSCR is a bit different from VKH. If you see the RB indulation, the subretinal septae, the fibrin, and the what we call bacillary detachment of the photoreceptor myoids. So if you see features that is suggested for VKH, we will go with the VKH treatment. However, sometimes confusion happen even with expert people. I always tell that if there is a doubt about the diagnosis, don't treat. Just observe the patient for a few days, then the picture will be complete for you. If you don't have access to the ICG. If you have access to ICG, you can solve the problem within 1 hour. But if you don't have ICG, don't treat, because if it's CSCR and you are going to give the patient IV methylprednisolone, unfortunately it happened. The patient can end up with massive serous detachment and PED, RBE rib, and subretinal hemorrhage. And if you wait for VKH for a few days, usually the disease will progress very fast. Within 2 to 3 days, you will see the subretinal fluid start to increase, unlike the CSCR. So CSCR don't behave like VKH. CSCR is slowly progressive. VKH is fast progressing disease. The best thing is to refer the patient if you are in doubt to do ICG. EDI OCT is very helpful if you have in your hospital OCT that has an EDI feature. So just measure the choroidal thickness. CSCR, they usually have like 400, 500, but VKH, the thickness will exceed 800 in most of the patients in initial onset. One test that we are doing only for research purposes is not available worldwide, the red flow, the choroidal blood flow using laser speculography, but we did it only because we have the luxury, we have the machine, and we tested this machine. It was very sensitive. The choroidal blood flow is severely impaired in VKH. However, it is normal or slightly high on CSCR.
Right. Thank you, Dr. Baloushi. I think you have covered all aspects, and especially what I requested you about that window period concept, which was presented also in SOS 2023 here. So our all members in the WhatsApp group and other people will really benefit from this video and your very experienced talk. So I want to thank you once again, especially I know you were very busy, and from your very busy schedule, you spared this time for us to teach us, to guide us about this, and especially our WhatsApp group, the ophthalmologist. And we will be looking forward to you for more teaching sessions.
Yeah, most welcome, Dr. Naeem, and thank you, Dr. Alim. Thank you for the invitation. I hope it was helpful, and inshallah we will meet and we will have other sessions in the future, inshallah.
Thank you, Dr. Baloushi. Thank you.
No, most
welcome.
welcome.
Assalamu alaikum wa rahmatullahi wa barakatuh.